Hi, so now we're going to go on to Module 2. We've just discussed what breast density is and why it's important, including the masking effect and the increased in breast cancer risk for women who have extremely dense or heterogeneously dense breasts. We're going to move on to supplemental screening, which is included in the second part of the breast density notification law. The intended learning outcomes of this module include to differentiate between supplemental screening technologies and their relative ability to increase cancer detection, including ultrasound and MRI, and to counsel women considering testing about the benefits and risks of supplemental screening. So the supplemental screening tests are primarily ultrasound and MRI used for screening. Tomosynthesis and molecular breast imaging are emerging technologies which are variably available across the country. What's important about the supplemental screening technologies is that all have been demonstrated to increase cancer detection. They've been studied and they can increase the numbers of cancers that are detected. However, none have been proven to decrease mortality or morbidity from breast cancer. However, none has been proven to decrease mortality or morbidity from breast cancer, and none is currently recommended by the major organizations when a woman has increased breast density alone. So tomosynthesis is a digital X-ray mammogram, which is performed in addition to a regular digital mammogram. As opposed to having a mammogram taken from just a single projection for both the CC and MLO views, a tomosynthesis image is obtained in an arc with multiple images obtained across the arc of the tube motion. This results in multiple images that can then be scrolled through, and in effect, they result in a separation of the breast tissues. And the virtue of the tomosynthesis imaging is that you can separate the different layers of the breast tissue and remove the superimposition, which is a major factor in standard mammographic imaging. Tomosynthesis is a relatively new technology. It has been studied and is FDA approved. The large study performed in 2014 demonstrated that it was able to increase cancer detection for women with all breast densities by approximately 41%, and it resulted in a significantly decreased recall rate from a screening study by removing the superimposition of the tissue that I previously described. Overlapping tissue is a major cause for women being recalled from their screening studies, and tomosynthesis will be significantly improving our ability to read through that and not have women be recalled for additional imaging. The risks of tomosynthesis, initially, the FDA approval included having approximately 2 times the radiation dose of a regular mammogram. However, with further research, and now it is implemented in the clinic, we can synthesize 2-dimensional images from the 3D images, which result in a decrease in the dose closer to that of a regular mammogram. Tomosynthesis does result in an increased interpretation time, and that does vary with experience, but will still remain longer interpretation times than for a regular 2-dimensional digital mammogram. Screening breast ultrasound is widely available. Ultrasound machines are available in all accredited breast imaging offices, and they have been studied with regard to being a supplemental cancer detection method for women with dense breasts or who are at high risk. A study that was reported in 2008 was a large study of looking at women who are at high risk for breast cancer and who also had dense breast tissue, at least 50% increased density, so heterogeneously dense or extremely dense breast tissue in at least one quadrant of their breasts. And this study revealed that in the first year of evaluation, women who had negative mammograms and underwent screening breast ultrasound, there were an additional 5.3 cancers detected in 1,000 women in just the first year. This then was carried out for 2 further years, and in years 2 and 3, there were, for each of those years, 3.7 additional cancers per 1,000 women scanned. So this was a demonstration that this supplementary screening can increase cancer detection, which is a good thing. The problem is that there is a cost to that increased detection. In this case, the cost was a relatively low positive predictive value when mammography and ultrasound were combined. A typical expected positive predictive value from mammography alone is anywhere from 25 to 40%, meaning when a biopsy is recommended, how often will that biopsy reveal cancer? 25 to 40% of the time, that is the accepted goal for breast imaging. In this study, when ultrasound was combined with mammography, the positive predictive value was as low as 11%, which meant that only 11% of the time when a biopsy was recommended did it actually result in a diagnosis of cancer. The equivalent way to state that would be there were a larger number of false positives when screening ultrasound was added to mammography. The study was then repeated in Connecticut, which was the first state to enact the breast density legislation, and 3 separate sites in Connecticut reported in the first 2 to 3 years after the initiation of the breast density legislation. They studied their women who had undergone breast imaging with mammography and had negative mammograms and who were then offered screening breast ultrasound. And their initial data was very similar to the study which was reported in 2008. And their resulting incremental cancer rates were approximately 3.2 per thousand to approximately 1.8 per thousand. And their positive predictive values, unfortunately, were similar or even lower in the range of 6 to 7% positive predictive values. So they had a lot of false positive studies that were the result of adding a screening breast ultrasound. So it is a trade-off, increased cancer detection versus false positive results. And these were for women who were at all risk levels, high risk, intermediate risk, and low risk, but they did have dense breasts. So screening breast ultrasound has more recently been studied. In 2015. There was a study done to see how cost-effective screening breast ultrasound was for women with dense breasts. And this study looked at women who were between the age of 50 to 74 years. They had heterogeneously dense or extremely dense breasts, and it looked at the cost-effectiveness of the studies both on deaths averted as well as quality-adjusted life years gained, which is a way of looking at the benefit of a screening test. And for their study, their results show that there was 1.7 quality-adjusted life years gained per 1,000 women who had the screening supplemental ultrasound done. There were 354 biopsy recommendations in those 1,000 women for a cost-effective ratio of $325,000 per quality-adjusted life year gained, which was felt to be a very high cost for a very low yield of additional cancers and life years gained. Automated ultrasound is a technology which has been FDA approved. It is of limited availability in the U.S. at this time. It is an automated way to scan the breast as opposed to having a physician or technologist scanning the patient. The machine is technologist directed. It generates a tremendous number of images, up to 1,000 images per study, and the clinician can scroll through the images to look at the breast ultrasound information. To date, there are limited outcome studies, and so it is not widely used at this point, but with further study, it may become more available in the clinic and may facilitate scanning patients more quickly when they have dense breasts. MRI is another modality that has been proposed for screening in women with dense breasts. It is a powerful magnetic field that is used to generate images. It does not involve radiation. However, it does require an intravenous injection of gadolinium. It is not recommended for women who are pregnant, have a pacemaker, have incompatible implanted metal, either intentionally implanted or accidentally within the body, for women who have impaired renal function or who are severely claustrophobic. So it's not a study that can be done on just anyone. There are select patients who can have MRIs done. The image that you see at the top of the screen shows 2 MR planes of a woman who had a negative mammogram. And she underwent MR because she was at high risk for breast cancer, and there is a very easily seen area of increased contrast enhancement in the posterior aspect of the breast, which was not apparent on the mammogram, and this was an invasive ductal carcinoma. This modality was studied, and it was an extension of the ultrasound trial that I described previously, where women had 3 consecutive years of negative mammograms and negative breast ultrasounds. Those women were then offered a round of MRI screening as part of their study after negative studies for 3 years. It turns out that that only 58% of the women offered the MRI accepted the MRI. And this resulted in 612 women who underwent MRI scanning. Again, it's important to note that they had 3 years of negative mammograms and negative ultrasound. The yield of supplementary yield of cancer detection was 14.7 cases per 1,000 women scanned, which is a significant supplemental yield of breast cancer in these women who previously on their other imaging studies were considered normal. Again, this is at a cost. Anytime we increase cancer detection, there is a cost. In this case, MRI specificity was lower than with mammography alone, and that correlates to a positive predictive value in the range of 19%, which was significantly below the positive predictive value of mammography alone. So the trade-off is increased cancer detection versus lower positive predictive value, more biopsies performed. And in the case of, in this study, the recall rate was also significant in that 31% of the women were recalled from their MR studies, which meant that they had to come back for a separate visit to have either repeat mammographic imaging or ultrasound, second look ultrasound to look for the MR finding and see if it could be identified under sonography. So these are considered the downsides of the increased cancer detection for MR. Molecular breast imaging is an emerging technology that is available in some institutions. It involves a radioisotope injection of technetium-99m cestimide, which requires an intravenous injection. The radiation dose has changed through the years and has now become more acceptable for breast imaging, and it has a dose, can be done at a dose similar to mammography. The resolution required for mammography has also been fine-tuned, and it is a high-resolution scan that is significantly more detailed than for the whole body imaging. In a study reported in 2015, there were 8.8 additional cancers per 1,000 women who underwent the molecular breast imaging compared to women who had mammography alone. So again, a large incremental increase in cancer detection. Recall rate was increased to about 17% for these women, whereas for mammography, the goal recall rate is between 5 and 10%. However, there was no difference in the positive predictive value for the molecular breast imaging versus mammography alone. So it was better since the specificity of the examination was better, and there was less of a dramatic false positive rate compared to ultrasound or MRI screening. However, it's important to note that for this, as well as the ultrasound and MR screening, no mortality reduction data is available. And now we'll move on to Module 3, which is recommendations for patients with dense breasts on mammography.